Sure. Thank you, Professor DeFore, for your nice introduction. And thank you and the committee for organizing this great webinar. It's my huge privilege to join. Today, I'm focusing on diet. Before doing so, I want to show briefly about my own research interest. First one, from the primary prevention perspective, my group has been interested in identification of new risk factors, including diet, lifestyle, and elucidate potential mechanisms for both liver disease and liver cancer. Liver cancer disproportionately affects minority population. Another line of my group research interest is to address health disparity and global health. And also we have some ongoing biomarker study to in the field of risk stratification, early detection and diagnosis. Lastly, among the individuals with liver disease, we are interested to identify the potential interventions to improve the quality of life. For the sake of time, I will focus on diet for today's presentation. I will start with a very brief overview about the liver cancer, which is the 6th most common cancer worldwide. Because of the poor diagnosis, is the 3rd leading cause of cancer-related deaths. Liver cancer has global disparities. For example, liver cancer disproportionately affects people living in some low and middle income countries, such as Sub-Saharan Africa and South Asia. And we know quite a lot about the known risk factors for liver cancer, as some of those are summarized here, including the chronic hepatitis B virus infection, HCV infection, and aflatoxin and alcohol. And those risk factors have significant contributions to liver cancer risk because of the prevalence, speaking the heterogeneity of liver cancer worldwide. And also liver cancer or liver disease has been on rise, unlike many other cancers or diseases. It is a recent data projection of both liver cancer and disease. As you can see, there are a strong increasing trend in different countries worldwide. In terms of liver cancer in the US, US has a low incidence historically, but in the past 3 decades, they have witnessed about 3-fold increase in liver cancer since the 1980s, projected to be the 3rd most common cancer-related death by 2040. And the etiological landscape of liver cancer in the US has been changing because data has suggested that over 60 or 70% of liver cancer in the US are not HPV-CV related. It's more maybe vitality disease driven factor. For those known risk factors, some studies show that up to 30% of liver cancer cases in the US cannot be explained by those known risk factors. And speaking to the unmet need to identify new risk factors. One of the new risk factors my group has been interested in is on diet. What we know about diet and liver cancer. This most recent data are summarized by the World Cancer Research Fund, American Institute for Cancer Research. As you can see, beyond heavy alcohol drinking and aflatoxin contamination of foods, and potentially coffee as a protective factor, most other diet and lifestyle factors has been falling into the categories with limited evidence. So to address this knowledge gap, my group has been working on the relationship between diet and liver cancer. In fact, there is a strong biological plausibility to support the diet with liver carcinogenesis. As shown in this oversimplified cartoon, you can see that dietary factors, along with other lifestyle factors, can biologically impact different molecular pathways, ranging from inflammation, insulin resistance, gut dysbiosis, hormone, lipid metabolisms. In all of these pathways has been closely relevant to different stage of liver carcinogenesis. What we have found so far is that, I summarized very briefly in this slide, we have found some nutrients, single food groups, or dietary patterns associated with the risk of developing liver cancer. inside the box, we also found some lifestyle factors using the energy balance related factor, like obesity is working as an example. I will focus on diet in today's presentation. In terms of diet, we have been using some longitudinal prospective cohort studies of initially healthy individuals. For those studies, for example, for nurses, health study, health professional follow-up study, 2 prospective cohort studies have been established in either 1980s or 70s with a repeated assessment of validated dietary intake. We have comprehensive information on other covariates with the incident primary liver cancer as an outcome. What we found is that, as an example, we found that whole grain intake associated with lower risk, and some of inverse association was also observed for fiber. For whole grain, we believe this is the first study in the population-wide showing that about 15 grams per day of whole grain intake, equivalent about 2 pieces of whole grain bread, is associated about 10% lower risk in this study. We also replicate these findings in even larger population-based cohort study, namely the NCI or NIH-ARP study. Based on over 900 incident liver cancer cases, we basically observed the same inverse associations with whole grain and some with the fiber intake. We also look at the sugar sweetened beverage intake from the data from the Women Health Initiative study. We can see from here is that comparing those participants who consumed at least 1 serving per day of sugar sweetened beverage have about almost 2-fold increased risk after we adjusted for the current known risk factors for liver cancer. We didn't see much for artificially sweetened beverage in this population, partially because the consumption level was pretty low at that time. We also look at other foods using the yogurt as example. Yogurt, as you know, is a food produced from milk by lactic acid producing bacteria. In this study from the ARP, we found that higher yogurt consumers have about 40% lower risk of chronic liver disease mortality. To further understand the potential mechanisms of yogurt and gut health, especially in liver, we have published one of the first population-based studies showing that higher yogurt consumers have lower levels of circulating CD14, which is a surrogate biomarker for gut barrier function, suggesting that yogurt may potentially interact with the gut barrier function to confer its effect on GI diseases, including yogurt or how the yogurt intake impact the gut microbiome. We also have been in progress of looking at yogurt and plasma metabolomics profiles to further understand the potential mechanisms supported by the Cancer Society. Beyond looking at the single foods, nutrients, or beverages, we also look at dietary pattern. In this case, we have looked at the dietary inflammation potential, where we have identified 39 food groups most predictive of some inflammation biomarkers, including IL-6, CRP, and TNF-alpha. Once we have identified this pro-inflammatory dietary pattern, we link that to the future risk of developing liver cancer and see that participants with high pro-inflammation diet potential have about 2-fold increased risk of developing liver cancer, and after accounting for other known risk factors. Beyond inflammation, we also found that dietary pattern promoting insulin resistance is also associated with the liver cancer risk as well, suggesting that you can reduce the insulinic and inflammation potential of the diet. The risk of developing liver cancer can be reduced. For the sake of time, I'll just give you very quick examples. Of course, we have looked at other For example, nutrients, like we found that the polyunsaturated fatty acids associated with lower risk. We have also looked at other food groups, including fish, poultry, vegetables, other dietary patterns. We did find both some inverse association and positive associations. For example, we do observe some inverse association with fish and poultry, but positive associations with high-fat dairy and processed meat. In terms of next step, clearly, as I mentioned, in novel or genetics or multi-omics, including microbiome, will help to facilitate, further elucidate the potential mechanisms and the underlying diet and the liver health. This can help inform the disease etiology and precision nutrition prevention. And for the studies I have shown here, like I mentioned, all healthy individuals in the cohort study, there is I might need to study how the diet impact the incidence and progression of different stage of liver disease. In other words, whether people already with alcoholic or non-alcoholic fatty liver disease or liver cirrhosis, how the diet can improve their progression outcome. All those studies that I have presented are predominantly from non-Hispanic Caucasian population. To my knowledge, the studies in diverse racial ethnic populations are very limited, especially given the fact that different populations have different eating habits or culture of eating. So there is a need to determine the specific diet and nutrition pattern that impact liver outcomes in diverse population in the context of one and what should we eat. And lastly, the study I presented all adults. As we all know, that the studying the impact of diet across the lifespan will be very interesting. For example, whether the early dietary intake or pattern may be relevant to liver health remain largely unknown. Lastly, among the individuals with different stages of liver disease, how the diet can improve the quality of life in the context of like food as a medicine, even for patients with cancer of HCC, whether the diet can improve the outcome in the context of cancer survivorship. Ideally, we can translate some population-based epidemiological study to refine the clinical guidelines. None of those work would be possible without the support of the committed study participants, colleagues, staff, and collaborators. And more importantly, I have the privilege to work with a group of outstanding students, postdocs, and junior faculty, and appreciate support. And that's it. I would love to have any questions from you. Thank you.
Thank you very much for sharing all this information with us. And we just check if nobody has hand on. I think, yes, Professor Amadori, please.
You're muted, Dr. Amadori. Sorry, you're muted. Yeah.
Yeah. Thank you very much for your very interesting talk. I have two questions. You presented the list of countries with the different risk factors. And if I understood right, you put US and Western world and alcohol consumption. And for, let's say, China, which is, of course, the overwhelming main country. So the Chinese do not drink or they do not abuse alcohol?
I think that also great question. Depends on the where the study was conducted. Is also a lot of variations in terms of alcohol intake in different parts of China. The slide I showed is a very overall overview about the known risk factors of liver, known risk factors. HBV, for example, is pretty prevalent in the South Asia and Africa, where there is CV is less prevalent comparing to the developed countries. I think that speaks to the needs of studying the impact of diet on different etiologies of liver disease or liver cancer.
I have a question for you. When we advise our patients, what we should tell them about vegetable and fruits is the same. You put them in the same bag, eat fresh products, or you go more for vegetables than fruits.
Good question. Recent meta-analysis found that the vegetable intake, especially green leafy vegetables, associated with lower risk, but the fruits, overall fruits intake is not associated with risk. And one of my postdoc collaborator has also found a similar pattern in another recent study. It seems very interesting that the vegetables associated with lower risk, but not fruits. We don't know much whether that's the fructose contained in the fruits or other factors may driven the null association with fruits. Yeah.
And when the patients are treated, well, let's say like that, when the patient has been diagnosed with HCC, is it too late for them to change the diet? As some patients, they know that for years they didn't eat correctly. They are diagnosed for HCC, and then they become fanatic. They deprive themselves from everything, and they eat just, salad the whole day, but nothing else, no chocolate, nothing. Is it worth it to really stop everything that you like when you're diagnosed with HCC?
Thank you. Great question. I think it's never too late to make good changes in terms of dietary intake. However, I'm not aware of any large scale study showing the evidence among the patients with liver cancer, understandably because the patients are unfortunately have poor prognosis. But with the more early detection or better treatment, I guess hope the patients will have a better survival going forward. In that context, studying the impact of diet on the survivorship among patients with liver cancer will be warranted. Hopefully, we'll have more evidence-based results to help support the potential clinical guidelines. But so far, if you are eating healthy, from other cancer survivorship research, I think it's never too late to make the change. Yeah. I would guess would be the same for patients with liver cancer. Yeah.
So there is no specifics in these recommendations which are specific for hepatocellular carcinoma. They actually apply also for other cancers.
Yeah, I mean, typically speaking, those already known protective factors for human health or other major cancers seem also play a role in liver cancer, although the magnitude of association appear to be a little bit stronger for liver cancer, in a sense that is understandable, intuitive to me, because liver is a major organ for metabolism and most relevant to diet. Yeah.
I would have a question as well.
Yeah, please, Pompilia.
So we know that the estrogen has a benefit in the patients with hepatocellular carcinoma. So like a prevention somehow. We see this in men and women in the prevalence of HCC. My question is, should we recommend to the patients to eat much more hummus or chickpeas, for example, because this we know that contains some more estrogen, and in this way we can increase a bit the quantity of estrogen that they take. It's not only related with the estrogen, but also to changing the body composition a bit.
Good question. As you noted, there is a strong interest to study the gender differences in terms of liver cancer. Hormone is one of those major hypotheses, but to my knowledge, the current population-based study on circulating estrogens or testrones and liver cancer in the early stage, the current doesn't support so much about hormone estrogen hypothesis. In terms of diet, is an interesting question. I'm not aware of any such study ongoing, but should be interesting to study in the future. Yeah.
Thank you.
You're welcome.
Do we have? I don't see any.
So if you want, I just ask another question because Pompilia brought me to the idea. There is an increasing a number of lung cancer in women, because they started to to follow the man and increase their their attitude to smoke. So they wanted, okay. So there is a similar increase also for liver cancer in women.
The increase in
smoke, I mean, yeah.
Yeah, good question. In the US, the increasing trend was seen both in men and women, slightly a little bit pronounced in women. Yeah.
So smoke is a smoke is
smoking.
a positive risk factor.
Oh yeah, smoking is established a risk factor for liver cancer, and also it takes individuals for maybe 15 or 20 years to get to the normal, to get to the risk as a normal general population if they quit smoking. Yeah, smoking clearly is a risk factor. Yeah, thank you for the question. Yeah.
And I have another one for you. We all have these cytochromes and different polymorphisms, are metabolic enzymes in the liver. They have big effect on drugs metabolism. They have effect on other metabolites. So this recommendation, they should probably be also a little bit adapted based on the metabolic equipment of individuals in terms of polymorphism in their cytochromes, no? Or in their excretion capacities, but I know probably there is no data on that.
I'm not aware, but you bring up a great point in terms of taking into account the genetic predisposition, as well as in the context of personalized prevention. Yeah.
I thought about this because smoking, there is some data here on polymorphism and the risk of HCC in smokers based on specific polymorphism. That's the reason I was asking.
Yeah, great point. Thanks.